Welcome to an in-depth look at the Bengaluru Document, Recommendations for Expert Witnesses in Fetal Radiology Imaging. This document, sequel to the Kochi Fetal Radiology Declaration 2025, was prepared by Dr Srinivas Shentar, a leader in the field and recipient of the National Fetal Radiology Leadership Award 2025. As the landscape of fetal imaging evolves, so do the challenges faced by radiologists, legal professionals, and patients. This video will guide you through the key recommendations, current challenges, and the path forward for expert witnesses in fetal radiology imaging. Let's begin by understanding the context and significance of these guidelines. Bengaluru Document serves as an educational resource, offering consensus-based recommendations for radiologists in India. Its primary aim is to provide clarity and direction in the complex field of fetal radiology imaging, especially when it comes to legal proceedings. The guidelines are rooted in the best available evidence, but they also acknowledge the importance of local resources, equipment capabilities, and individual circumstances. This ensures that recommendations are practical and adaptable, rather than rigid rules that ignore the realities of clinical practice in India. Recent years, there has been a noticeable surge in litigations against doctors, particularly in the area of fetal imaging. This trend has caused significant concern within the medical community, leading to the widespread practice of defensive medicine. Defensive medicine, while intended to protect practitioners, can reduce efficiency and increase healthcare costs. It also places additional stress on physicians, sometimes resulting in burnout and the need for retraining. Understanding the root causes of this litigation surge is crucial for developing effective strategies to protect both patients and healthcare providers. Defensive medicine refers to the practice of ordering extra tests or procedures primarily to avoid litigation, rather than to benefit the patient. This approach can lead to unnecessary interventions, higher costs, and sometimes even reduced quality of care. The document highlights that defensive medicine is often a response to unrealistic expectations about what imaging technology can achieve. It's important for all stakeholders, doctors, patients, and the public, to understand the strengths and limitations of diagnostic imaging so that trust can be rebuilt and misconceptions dispelled. Medical negligence claims in radiology are complex and multifactorial. Errors can arise from observer mistakes, misinterpretation, communication failures, or systemic issues like inadequate training. The legal remedies available to patients include complaints to medical councils, consumer courts, civil courts, and even criminal complaints in cases of gross negligence. However, the Supreme Court of India requires proof of gross negligence for criminal liability, while civil liability can arise from less severe lapses. The lack of unbiased, evidence-based information complicates the legal process, making the role of expert witnesses even more critical. To address the challenges in adjudicating medical negligence, the document calls for an unbiased, transparent, and evidence-based system. Such a system would quickly categorize cases into those that clearly do not involve malpractice and those requiring deeper investigation. This approach helps filter out frivolous cases and ensures that genuine concerns receive the attention they deserve. The system must also be robust, transparent, and adaptable to local realities, avoiding unnecessary delays and fostering trust among all stakeholders. Key recommendation is to bridge the knowledge gap between medical and legal professionals as well as the public. This can be achieved by presenting complex medical concepts in simple language, developing concise and accessible guidelines, and fostering collaboration between the legal and medical communities. By improving access to accurate information, the system can ensure fair judgments and reduce misunderstandings about the capabilities and limitations of prenatal ultrasound and diagnostic imaging. Diagnostic imaging performance in fetal radiology is influenced by a variety of factors. These include maternal conditions, fetal position and development, the capabilities of the imaging equipment, and the clinical setting. For example, maternal obesity or inability to return for follow-up scans can affect image quality. Similarly, the type of ultrasound machine and the resources available in different healthcare settings play a significant role. Understanding these variables is essential for fair assessment of diagnostic outcomes. Every diagnostic test, including fetal imaging, is characterized by its sensitivity and specificity. Sensitivity refers to the ability to correctly identify those with a condition, while specificity is about correctly identifying those without it. No test is perfect. False positives and false negatives are inherent. The document emphasizes that these limitations must be understood and accepted, and that not every misdiagnosis is a sign of negligence. Instead, tests should be chosen and interpreted based on their known strengths and weaknesses. Professional and academic organizations play a crucial role in defining standards of care, updating guidelines, and ensuring ongoing training. They must collaborate with the legal fraternity to define medical negligence in clear, measurable terms. Regular updates to standards, structured training programs, and the establishment of expert medical boards are all recommended. These steps help ensure that care is consistent, evidence-based, and aligned with both medical and legal expectation. The document recommends that standards of care be updated every 3 to 5 years, reflecting advances in technology and local evidence. Training and accreditation processes should be structured, with refresher courses and modular programs for practicing professionals. This ensures that radiologists remain current with best practices and are equipped to handle the evolving challenges in fetal imaging. Such ongoing education is vital for maintaining high standards and minimizing error. To ensure unbiased expert opinions, the document suggests establishing dedicated statewide medical boards with rotating members and a diverse pool of expert witnesses. A masked review system where reviewers are unaware of the accused's identity can help reduce bias. These boards should represent a variety of clinical settings, ensuring that opinions are grounded in real-world practice and not skewed by the resources of a single institution. Document advocates for retraining modules for doctors accused of malpractice, developed in collaboration with the legal fraternity. This approach shifts the focus from punitive measures to education and improvement. The no-fault liability model used in some countries provides fixed compensation for victims without assigning blame. While the system has its limitations, it encourages reporting and ensures some degree of compensation for all affected parties. Expert witnesses in radiology have a duty to provide unbiased, scientifically accurate information to aid the judicial process. Opinions must be evidence-based, logical, and defensible. Personal opinions or speculation should be avoided unless supported by published, peer-reviewed research. The expert's role is not to exonerate or condemn, but to clarify the facts and help the court understand the complexities of diagnostic imaging. Medical guidelines are designed to improve future standards of care, but they do not instantly become the legal standard upon publication. Implementation takes time and resources vary widely across regions. Judging negligence based on newly published guidelines can be unfair and may hinder the adoption of higher standards. It's important for courts and stakeholders to understand this distinction and apply guidelines appropriately. Expert witnesses must consider local data and circumstances when forming opinions. Detection rates and standards from high-resource countries may not be directly applicable in India due to differences in equipment, training, and patient populations. Local evidence should be prioritized, and limitations clearly communicated to the court. This ensures that judgments are fair and grounded in the realities of Indian healthcare. Before providing an opinion on negligence, experts should review the ultrasound detection rates for the condition in question. If more information is needed, concerns can be referred to the ICRI committee for further review. Opinions must be supported by citations, with a summary of the relevance and limitations of the evidence. This systematic approach ensures that expert testimony is robust and defensible. Gestational age and trimester at which a scan is performed significantly impact the likelihood of detecting certain conditions. Some abnormalities are only visible at specific stages of pregnancy, and data may be limited for rare conditions. Expert witnesses must consider these factors when forming opinions and avoid holding practitioners to unrealistic standards. There are genetically influenced differences in fetal size and proportions between populations. For example, biometry standards developed in other countries may not be directly applicable to the Indian population. Expert witnesses should explain these differences to courts and avoid using foreign standards as the sole basis for judgment. This nuanced understanding helps prevent misinterpretation and unfair conclusion. Growth discrepancies, such as differences in limb length, may be difficult to detect before birth due to the limitations of current imaging practices. Guidelines typically recommend measuring only one side, and fetal position can further complicate detection. These inherent limitations must be considered when evaluating potential negligence, as not all discrepancies are detectable or clinically significant. Number of ultrasound scans performed does not necessarily increase the detection rate of anomalies. What matters more is the gestational age at which the scan is done. Some conditions are inherently difficult to detect, regardless of how many scans are performed. This understanding is crucial for fair assessment of diagnostic performance and for setting realistic expectations among patients and legal professionals. Conditions under which a scan is performed, such as the type of equipment used, patient body habitus, and fetal position, can significantly impact the quality of imaging. These technical and patient-related factors must be considered when assessing whether a misdiagnosis constitutes negligence. Not all limitations are within the control of the practitioner, and this context is vital for fair judgment. Marketing strategies for advanced imaging equipment can create unrealistic public expectations about what diagnostic imaging can achieve. High-end machines are not universally available or affordable, and most settings rely on standard equipment. Expert witnesses should clarify these realities to courts and the public, helping to align expectations with what is actually possible in routine clinical practice. Quality of stored images and thorough documentation are essential for fair assessment. Poor image quality may be due to inherent limitations, such as patient body habitus rather than practitioner error. Documentation should cover the totality of the scan, referral indications, and relevant clinical details. Reviewing prior imaging can help determine if a missed finding is a random error or part of a systematic pattern. Systematic process for assessing malpractice or negligence is outlined in the document. This includes evaluating the prevalence of the condition, detection rates, sensitivity and specificity of the test, and the presence of any technical or patient-related factors. By following a structured approach, expert witnesses can provide objective, evidence-based opinions that support fair and consistent legal outcomes. Consider a case where a prenatal ultrasound missed a cleft lip and palate. Detection rates for these conditions vary widely, even in countries with advanced equipment. For instance, detection rates for cleft palate remain low worldwide, and missing such anomalies is not necessarily negligence. The document recommends that expert witnesses be chosen from the same discipline with up-to-date knowledge and rigorous certification to ensure accurate and fair testimony. Another example, a woman lost her baby to a congenital heart condition that was not detected prenatally. The case review highlighted several factors. The patient did not return for a recommended follow-up, the detection rate for such conditions is limited, and technical factors like maternal obesity affected visualization. The judgment emphasized that not all anomalies are detectable, and missing them does not automatically imply negligence. Table 1 in the document lists maternal, fetal, equipment, and resource factors that impact the performance of fetal diagnostic imaging. These include maternal health, compliance, fetal position, gestational age, and the capabilities of the ultrasound machine. Recognizing these variables is essential for a fair and comprehensive assessment of diagnostic outcomes and potential errors. Able 2 provides detection rates for a wide range of conditions identifiable by prenatal ultrasound. These rates vary significantly, and many conditions have low detection rates even with optimal equipment and expertise. Understanding these statistics is crucial for setting realistic expectations and for fair legal assessment of misdiagnoses. Able 3 outlines measures for guiding opinions on malpractice and negligence. These include prevalence of the condition, detection rates, test sensitivity and specificity, and the presence of technical or patient-related factors. By systematically considering these parameters, expert witnesses can provide balanced, evidence-based opinions that support just outcomes in legal proceedings.